Today we'll cover special clinical scenarios uh, that fall into the category of hypercortisolism, which is not the florid, which does not present as a florid cushingoid features. We will touch base in these clinical scenarios and just have an introduction for each one of them, and then we'll have a case vignettes to demonstrate how these scenarios present in real life and how to manage it as well. So the first clinical entity is subclinical Cushing, and essentially it's a misnomer. It's simply mild Cushing. Irrespective of the source, be it from the adrenal gland or from the pituitary, the patient does not usually present with any cushingoid features apart from a bit of high BMI. They could and they usually have metabolic derangement consistent with Cushing's, a bit of hyperglycemia or hypertension and or osteoporosis. Please take note, osteoporosis related to steroid or to cortisol is preferentially vertebral. Now, the principal the principle in the management of subclinical Cushing is we do not need to rush into treatment. However, we do not need to be very complacent. Hypercortisolism is associated with a lot of detrimental effects on the brain. It could cause brain atrophy, cognitive impairment. It is associated with increased morbidity and mortality in general. The question is, whom are we going to investigate for subclinical Cushing when the patient is not cushingoid right in the front? And these are this is the answer. These are the clinical scenarios when I investigate for excess cortisol. Adrenal incidentaloма, obviously, a young person with unexplained osteoporosis or severe osteoporosis or osteoporosis refractory to anti-resorptive treatment. Obviously, on the proviso that there's adherence to treatment. Polycystic ovarian syndrome, and the new terminology is reproductive metabolic syndrome, and we often tend to forget that this syndrome diagnosis is actually a diagnosis of exclusion. You do need to exclude Cushing's, and you also need to exclude congenital adrenal hyperplasia. So this one single clinical entity where you have to stimulate the steroids to check for CAH, for 17-hydroxyprogesterone, and later on suppress it with 1 mg DEXA suppression test. Refractory hypertension, any patient with the 3 or more antihypertensive medication need to be investigated for secondary causes as per guidelines, on the proviso again that the patient is adherent to his or her medication. Another forgotten or underdiagnosed is hypogonadotropic hypogonadism. In this one, we will have a designated lecture about this particular complicated topic. So these are the usual scenarios when I test for excess cortisol in someone who does not have any cushingoid features. Now, how do we test for it? Well, to start with, 24-hour urine-free cortisol is of a low yield in this scenario. It's often normal. So 1 milligram dextrosuppression test usually comes in the gray area between 50 and 138 nanomole per liter. I've put a study that done recently for histologically proven adrenal Cushing that show, and the criteria for diagnosis that showed a very high yield is dextrosuppression test, well, partially suppressed as opposed to adequately suppressed, plus low ACTH and or DHEAS. So they use this criteria with a very high specificity. Again, late night salivary cortisol usually is mildly elevated. The low dose dexamethasone suppression test, the 48 hours, I have not used it for a while because we do have fairly good assay, particularly the salivary and the DEXA suppression test, that give us a consistent result which help us to rule in or rule out the diagnosis. Again, you do not need to rush into the diagnosis. You could manage even medically. You could, as some authorities suggest, to surround the diagnosis. However, as I mentioned before, don't be too complacent and don't leave it for too long. You could buy some time until it declares itself. Now, we'll move into another clinical entity of hypercortisolism, that's bilateral adrenal Cushing. Often it's a mild form and often present later in life. There was a lot of categories and classification of this syndrome. So either micro or macro. And if it's microadrenal, is it pigmented or non-pigmented? And each one of them has a different cause, but they, as I said, they usually present later in life with mild Cushing's. These are a snapshot of the genes that could cause the bilateral adrenal Cushing's, and I put this slide just to highlight the RAUC5 mutation, which is newly discovered. Now, how to manage it? Well, we tend to resect the large adenoma and hope for the better. We can always opt to treat medically before you opt surgery. So that's the usual approach. Now, adrenocortical carcinoma, this is need to be taken obviously seriously. Again, we tend to see it in the context of new onset virilization in a menopausal female, well, in females in general, and or as an adrenal incidentalloma with a large adrenal adenoma that doesn't look benign in terms of it tends to be lipid poor with irregular contour and a poorly defined margin. Adrenocortical carcinoma can lead to excess cortisol or its precursor. Either way, you'll end up with severe hypertension associated with low renin and aldosterone. How about ectopic Cushing? Now, we've touched base about this topic before, and what I want you to know here that it tends to run a very rapid course. It can present with non-Cushingnoid feature and severe hypokalemia. Once you think about it, it will be easy to pick it up. The patient will be sick because he has cancer. And it does not suppress the 8 milligram DEXA suppression test. The cortisol and the ACTH tend to be very high. And once you do the axial imaging, you're most likely to find a tumor. Now, there's only one exception, is when you have a carcinoid as an ectopic source for corticotropin. tend to be mildly raised. Now, how about pseudo-Cushing's? Obesity, morbid obesity, and poorly controlled diabetes, they all can present as pseudo-Cushing's, and these case scenarios, they tend to look Cushingoid. However, pardon me, they don't have all the features, particularly the proximal myopathy, the ecchymosis. In these circumstances, actually, I find salivary cortisol is most helpful, as it tends to be normal. 24-hour urine cortisol can be false positive mildly, and 1 milligram false DEXA suppression can be false positive as well. Now, how about anorexia nervosa and severe psychosis? These cases will have raised salivary cortisol, albeit mildly, but they tend to suppress well on the DEXA suppression test. Another clinical entity is the contraceptive pills. These will raise the cortisol binding globulin, and subsequently they will elevate the total cortisol level. And when we check for serum cortisol, we actually measure the total cortisol, and this will render the 1 milligram DEXA suppression test futile. And so the best way is probably to check via salivary cortisol. So, and I will present in the next few lectures a case vignette to take you through each single scenario of these.